Well, the important thing is you have to look at is what we can do to try to decrease sun exposure, because a lot of melanoma and skin cancers it's ultraviolet light. So keep covered up in the sunscreen like you talked about, and also it's skin checks. You got to be hyper vigilant about everything you do. If you see something weird, you see something strange, you got to be really vigilant on it. And especially you got to look at your family. If you have a family history of melanomas, you got pancreatic cancer, you got breast cancer, you got all these history in your family, then you got to keep a hyper acute on that. I better start thinking about, I better get skin checks dermatologically in a regular fashion. So, and also if you have a personal history, if you have a personal history of any of that, breast cancer, ovarian cancer, or those other lines of cancer, or of a cancer family syndrome, you got to start thinking, well, maybe I have a predisposition that I could have an underlying something happening, and I better be more proactive. What's super important is if you live in Florida and you have if you're light skinned, if you got freckles, if you have a blonde hair, it's weird. Blonde hair and red hair are really important. You should really think about getting screening for melanomas and skin cancers for sure. Also, because it's prevalent. Melanomas itself, it's about 2.5 to 3% of the white population. Non-white population, it's more roughly about. It's a lot lighter. It's more 0.25. It's 0.25 to 0.3, maybe 0.4. So it drops down. And there's a lot of different genetic tests that we can do for that if you have a concern about it as well in the family history. We can get into the whole genetic discussion as well if you want. But if you have a family history where you see a lot of cancers in your family, there are certain genes that you can look for melanoma. And if you're a BRCA, everybody talks about the BRCA gene, more on the 2 side of the BRCA, but it's a doubling. So if you're like a 3% and in the white population, then you can jump to like a 6 to a 8% chance risk of melanoma. So it's real important to get those screening done. So if you're sitting around and you say, oh my God, grandma had skin cancer, Papa had ovarian cancer, had colon cancer, and my aunt, you got to think, well, I got a lot of cancers in my family. Maybe I want to see my primary, mention that to my primary. Maybe we want to do some genetic screening. Because if that happens, then you're going to go to a dermatologist. You're going screening harder. You're going to get some genetic tests. If you carry those traits, then your family is going to get tested as well. So you just have to be hyper vigilant and say, oh, I got a dot, oh, it's changing. And just really take a look at yourself to be sure you keep an eye on that. And melanoma does weird things. It doesn't obey a lot of other cancer spreading ways. It just shows in weird places, so you have to really be hyper vigilant on follow-up too. It's just a scary disease. But squamous is a lot easier because it's more localized. You cure it by resection. You don't have to really do a vast, extensive surgery. Melanoma, the most important things is, number one, you got to get it out to negative margins. So you got to cut margins around it. Get good margins around it and get it completely out. And then also the important thing is, once it gets to a certain depth, if I talk about depth and Clark's level and talk about different depths of it, so we talk if it gets down to about up to like a 0.9 millimeter or a 1 millimeter depth, then you got to think about that to get to the lymph nodes. So you got to do lymph node sampling. So you use different techniques to try to find that first draining lymph node of that region. It's called a sentinel lymph node. We use different radiation type injection agents and blue dye and different dyes to track into those lymph nodes to sample the lymph node basin. Say it's like here, it's going to go here. If it's in the leg, it usually goes to there. If it's in the back, it can go here, it can go there, there. So we have to track to those first draining lymph node basins and sample the lymph nodes to say, did it get there? Because that's super important. It's not a therapeutic maneuver. We're not taking the lymph nodes out to cure the spread. We're taking the lymph node out, or maybe a couple, to say, did it get there? That's all we need to know. Because then you talk about if it got there, then your stage is up. So your stage is bumping. So now you got to talk about treatments. You talk about chemotherapy, although melanoma therapy is not, it's more checkpoint modulation, it's more immunotherapy. Years ago, horrible treatments. I mean, melanoma survival is terrible.
Really?
Oh, it's terrible.
So good
6% increase per year survival of melanoma since 2010 all the way to like 2000. It keeps bumping up. So if you're a stage 1, it's around 90%. I do the 90-60-30 rule. I don't know, it just seems easier to me. Is when we talk about stage 1 and 2, it's about 90. Stage 3, about 60. Stage 4, you're still looking at about 20 to 30% survival. Because the treatment modalities we have, people get scared of chemo because chemo is a rough drug. A lot of the chemos that people use and the medical field uses for other cancers and other therapies, they're not very directed. They tend to target more fast-dividing cells. So that's why people get sick on them, because it's not really hyper-focused on what it wants to do. It doesn't kill just a cell, it destroys a lot of other things. They're very effective, but they have side effects. Melanoma treatments are more directed at checkpoints. We call them checkpoint mutations. So they're more directed towards targets. Like when we talk about different targets, like two of the big ones is you talk about, there's like 4 big ones you talk about. It is a BRAF mutation, a MEK mutation, a PDL1, and a CTLA4. And it's all smorgasbord of words, right? But they all have different targets. So what happens is when we talk about the BRAF mutation, you talk about the MEK mutation, you talk about those are more involved in cell division. So what the drugs that we use for those, which examples would be like Zelborf and also Mekinist, are 2 drugs you use for those. And what it does is the melanoma with those markers, it wants to divide, right? So what these drugs do is help the body kind of decrease the division rate of the melanoma. You kind of think of it that way. Whereas the other markers, the CTLA4 and the PDL1, they're more involved in T cell and immune function. So the body needs to get a boost to help identify those cells, to say that's a bad cell. So what T cells do, T cells are T killer cells, so T cells go around the body and they help destroy bad things in the body. So what the melanoma cells is when the cancer cells is they start decreasing the body's ability to see them real well. And so what the drugs help do is they help the T cells, the killer cells, say, oh, that's a bad actor, I better kill that thing. So to put it like in the simplistic terms, you have the anti-division agents that help decrease the division of the bad stuff, and then you have the killer division that helps the T cells in our own body kill the bad stuff. And now there's a real exciting thing that just came out. It's tumor infiltrated lymphocytes therapy, TILs we call it. It's and Amtagvi, I think it's Amtagvi, is one of the new kind of drugs or treatments. What it does is it's really wild. It's kind of like CAR T therapy. So what they do is they take the melanoma, actually cancer, out of the body, and they take the tumor, and then they splice out the T cells, the actual immune cells from the patient's body, and then they divide it, make it more effective, the T cells, and then they take the patient and decrease they give the patient chemo to decrease their T cell levels in their body, and they infuse the hyper T cells back into the patient to start hitting all those bad melanoma cells that might be spread around the body. It's a big, long process. It's brand new. They're just starting to get it out. It's called TILS, TILs. But it's a super cool idea. A lot of the melanoma treatments are more geared towards making your body better, effective at fighting the melanoma. So it's an interesting way to treat. And unfortunately, though, is melanoma, before it gets to the lymph nodes, does much better. Melanoma, when it gets to the lymph nodes, it knocks it down. If it gets to metastatic around it knocks it down further. So it's an aggressive type of cancer once it gets to a certain point. But if you get the negative margins around it, it doesn't go to the lymph nodes, we can keep a good eye, and you have to be really, really vigilant about follow-up. But people do reasonably well with survivals on it. They really do.